Ladies and gentlemen, sorry I cannot join you in person. Today I will present our study on visual impairment due to retinopathy of prematurity and concomitant disabilities in the Netherlands. This study compares consecutive surveys within our country over a period of more than 40 years. I have no conflict of interest and neither have the other members of the team. In this presentation, I will give a short introduction to ROP and the national inventories we performed in our country. I then will talk about screening reductions for risk factor adjusted screening criteria and safety measures, the incentive to evaluate visual impairment due to ROP, and combine this with an inventory on concomitant disabilities in this at-risk population. The outgrowth of retinal vessels normally takes place in utero. Vessels start to grow at the optic disc at 16 weeks and reach the outer part of the retina at 40 weeks gestation, as you can see in the illustration on the left. You also see examples of a fully and partially vascularized retina. Balanced concentrations of growth factors such as insulin-like growth factor 1 and vascular endothelial growth factor are necessary for normal vessel development. Excessive production of these factors, mediated by retinal hypoxia, initiates ROP. ROP is characterized by an arrest of vessel growth and abnormal vessel development. Ischemia induces upregulation of vascular growth factors, resulting in dilation and tortuosity of the vessels as well as proliferation, all with the intention to supply enough oxygen to the developing retina. You see some examples of ROP and fluorescein pictures of neovascular complexes. The Netherlands is a small European country with 17 million inhabitants and the highest population density in the area. Together with Sweden, we are known for our prospective national studies on ROP. In our country, the NETROP 1 and 2 in 2009 and 2017 respectively. All Dutch hospitals involved in screening for ROP participated in the study, and this included pediatricians, neonatologists, and screening ophthalmologists. The goal of the inventories was to get more insight in ROP incidence and screening logistics, to optimize the screening program, and to evaluate outcome of ROP treatment. In 2017, we additionally evaluated the measures taken after the first NETROP study. Today, we focus on the safety of the screening guideline implemented in 2013. In this presentation, we will focus on the optimization of the screening program, the implementation of the new inclusion criteria included in the screening guideline after NETROP 1, and the safety measures to ensure no children with treatment requiring ROP will be missed. The purpose of screening is to identify infants with ROP in time to adjust ROP-related parameters, and this is something to be discussed between ophthalmologist and neonatologist, but also to identify and treat type 1 ROP at the appropriate time. Many efforts have been undertaken to establish universal guidelines for screening, but this appears to be impossible due to socio-economic factors and local level of neonatal care. As screening is distressing for the babies and time-consuming for the ophthalmologist, we intended to screen as less children as possible, but detect treatment requiring ROP in time. We wanted to focus on children at risk and keep a safety margin for outliers. And we also wanted to introduce specified risk factors in screening criteria to define the rather vague definition of high risk according to the treating physician. This meant that we performed a cost-effectiveness study following the NETROP 1 study. We defined safety margins, costs, effects, and QALYs, and developed a model that can be used by others when local health costs, life expectancy, and epidemiology of ROP are considered. Here you can see an example of results of the 2017 cost effectiveness study. On the top line you find different inclusion criteria for screening. On the second row, the number of infants with treatment requiring ROP that would be detected using this strategy. 39 should have been detected. On the third row, you find the number of screening examinations for every strategy, followed by the annual costs. On the fifth row, you see the number of persons with improved vision if this strategy would have been implemented, followed by the average cost for every PIV. There are only two strategies that would have detected all infants with treatment requiring ROP. And if you look closely, you can see that the current strategy, screening all infants with gestational age under 30 weeks and or birth weight under 1250 grams, or all infants with gestational age 30 to 32 weeks and or birth weight 1250 to 1500 grams, with one or more risk factor, is not the most efficient one. This did not surprise us that much because the same was seen after the first NETROP study. However, by then we were not brave enough and decided to keep on the safe side. So we reduced the number of children eligible for screening and wanted to be sure that we did not miss infants with visual disability due to ROP because they exceeded the screening limits. The more, as in the meantime, following the neoprom, higher oxygen targets were accepted and the age for active neonatal treatment in the Netherlands was lowered from 25 to 24 weeks gestational age, both potentially increasing the risk for more and severe RO. Therefore, we performed a study to detect infants referred to the institutes for the visually disabled and blind. We have two in the Netherlands, Royal Visio and Bartimeus. In our country, all children with visual disability are referred to one of those centers. We started this study in 2020. The institutes provided anonymized data on all infants referred with a diagnosis of visual impairment due to ROP for the period 2009-2018. These data were compared to 4 earlier identical inventories. Birth rate data were collected from the Central Bureau of Statistics and survival rates were obtained from the Dutch Perinatal Registry, Perinet. The current study was hindered by the introduction of the General Data Protection Regulation, as the collection of more detailed information, such as the duration of supplemental oxygen and artificial ventilation, was not allowed when this information could not be retrieved directly from the files of the Institute. These are the neonatal data of infants with visual impairment in 5 consecutive periods. Study number 5 is the current study. Study periods overlap as some infants are reported to the institutes later, so the incidences found in the current study are minimum figures. You can see that 53 children were referred to the institutes. Over the years, gestational age and birth weight of infants with visual disability, not surprisingly, decreased. Also, visual impairment due to ROP in relation to overall birth rates in the Netherlands decreased over the years and are comparable to other countries. This table shows the proportion of infants with different categories of visual acuity according to the WHO criteria. It is determined by the vision of the best eye. In the present study, 32 out of 53 children were visually impaired. The others had one eye that did not yet fulfill the criteria, had visual acuity just above the WHO criterion of 0.3, or were diagnosed as cerebral visual impairment. This is an overview of the percentage of concomitant disabilities in infants with visual impairment caused by ROP. Though the absolute number of infants with behavioral abnormalities and hearing deficit halved, the difference was not statistically significant. Overall, it seems a plateau has been reached in the incidence of concomitant disabilities. If we look at visual impairment caused by ROP in relation to estimated number of survivors and percentage of infants with concomitant disabilities in patients with visual impairment, both in relation to gestational age, we see that the amount of concomitant disabilities is high for all infants with gestational age under 30 weeks. 85% has at least one concomitant disability, whereas 75 have multiple disabilities. To summarize, up to now, no children with visual impairment due to ROP were missed after the introduction of the new screening criteria, confirming the safety of the guideline. The proportion of children with visual impairment and those developing at least one non-visual disability increases with decreasing gestational age. Despite unfavorable neonatal factors introduced in the study period, the incidence of visual impairment due to ROP remained low. Despite improvements in neonatal care, the number of infants with concomitant disabilities did not change. The number of infants with one or more concomitant disability remains high. So to finalize, as no infants with treatment requiring ROP would be missed, it was decided to reduce the number of infants that are objected to the burden of screening with another 25%. In the Netherlands, we experienced that close cooperation between neonatologists and ophthalmologists, monitoring and studying the effect of changes in neonatal care and evaluation of screening and treatment protocol increases the quality of care for neonates at risk for ROP, stimulates reflection on choices made, increases cost effectiveness. However, ongoing vigilance is necessary. Thank you for your attention. If you have burning questions, please send a mail. And if ever you would have the opportunity to come to the Netherlands, come by to say hello to this friendly chap seated near the entrance of our hospital.